To Ashwati? Yeah. IOL scaffolding, a novel technique in hypermature cataract surgery.
Good morning. My presentation is IOL scaffolding for hypermature cataracts. Aim of my study is to evaluate the safety, efficacy, and visual outcome following IOL scaffolding in hypermature cataract. We did retrospective study of 5 cases with hypermature cataract. Preoperative evaluation were done like uncorrected visual acuity, best corrected visual acuity, intraocular pressure, speculomicroscopy, slit lamp examination, biometry, and B-scan. Routine preoperative medications were given as like before the cataract surgery, and 2 cases had ficulitic glaucoma. So prednisolone, cycloplegic, and anti-glaucoma eye drops were given along with the injection mannitol. We included hypermature cataract with small hard nucleus with liquefied cortex and intact capsular rhexis intraoperatively. Out of 5 cases, 4 cases we did phaco and 1 case SSES, and IOL scaffold technique was done prior to the nuclear delivery. In phaco, we used a single piece foldable IOL, and for SSES, single piece rigid IOL. We used dispersive viscoelastics to protect the endothelium. Specular microscopy, the endothelial count more than 1500 were taken, were there in all cases preoperative, and none had the endothelial decompensation preoperative. With the cases with intact capsular rhexis, we washed the liquefied cortex. Small hard nucleus were lifted partly from the bag and IOL inserted beneath into the bag under the cataract, which acts as a scaffold to stretch the bag. And nuclear management was done with the IOL as the scaffold. These are the pictures showing IOL scaffold in phaco, showing injection of the foldable IOL, and the other case in SSES, injection of placement of the rigid IOL. And all had a good post-operative visual acuity. 2 cases did not come for follow-up after the post-operative day 3. None of the cases had PCR or zonodialysis, and post-operatively they had the normal IOP, round people, well-centered IOL in the back with relatively clear cornea. These are some of the pre-operative picture and the post-operative picture. So coming to discussion, why the hypermature cataract is challenging? Because it has a hard Brunnerson nucleus. They have the ficulitic glaucoma, so IOP will be high and cornea won't be clear, and difficulty in the IOL power calculation preoperatively, difficulty in making the capsular rhexis due to the poor visualization and the extension, can cause the wound burn due to the hard cataract, corneal endothelial damage, zonulopathy, and there is chance of PCR and nuclear drop. Also, the fibrous rigid anterior capsule makes the capsular rhexis difficult. The liquefied cortex or the dense floating nucleus makes the PC lax and floppy, difficulty in managing the nucleus and phaco. Also, the vitreous syneresis causes the floppy bag. There can be also zonular weakness. Dr. Amar Agarwal first introduced this IOL scaffolding technique. It is also used in glued IOL scaffolding technique and to prevent the PCR in cases requiring IOL exchange and to prevent the drop of the remaining nucleus in case of already PCR happened. Limitations of my study is small sample size and no long-term follow-up. Concluding, the IOL scaffolding technique stabilize small dense floating nucleus which makes a easy phaco chopping, stable inflation of the capsular bag which act as a CTR, reduces zonular stress, prevents the rupture of floppy PC. So, IOL scaffolding is a simple maneuver that protects the vulnerable PC and capsular bag zonular complex simultaneously in hypermature cataract. These are my references. And this is a small video showing lifting the nucleus after the rhexis and injecting the foldable IOL into the bag, rotating the IOL, making sure that it is filled in the bag and it's act like a CTR, stretching the bag, thus the phaco can be done easily with the IOL acting as a scaffold beneath. And the phaco is done in the pupillary area, not too anterior, so as not to cause the endothelial damage. Thank you.
Yeah. Were there any cases in which it had gone into the sulcus while injecting the IOL?
No, ma'am. No, ma'am. We made sure that the IOL goes into the bag, then we does this. And if the capsular rex is extended, we did not continue with this IOL scaffolding technique, only with the intact capsular rexes. And we are sure about that the IOL in the bag, we did follow with this technique.
Why should it be? Actually, normally a three-piece lens is put in the sulcus most of the times. Especially the scaffolding tech is done for PC rents where still the nuclear pieces are remaining in the AC. To avoid a drop, it is done in the sulcus. So you can always put in the sulcus also. And we can, that is another reason why you put in the sulcus. Because you said it's a very simple maneuver. I think not all of us can agree with that statement. You are putting a lens, already there's a nucleus in the eye and it's very close to the cornea you're working. It's a very small series of high cases. We might have tasted success, but I think it has its own problems. The problems are, cleaning the bag, removing the cortex. Even it is a hypermature cataract, there'll be still, sometimes there'll be some cortex. So if you put in the thing, again, put the IOL in the bag, cleaning up the capsular bag would be little actually tricky. So you all use single piece lenses or three piece lens also?
Single piece lens.
Single piece lens. Okay. Even a three piece, actually, ideally it is a three piece lens in the sulcus, which actually acts like a scaffold. And after completing the case, it can be either left there or it can be put back into the bag. So that is the actual thing.
Okay.
So it's a hypermature Morgagnian cataracts.
Yes, sir.
Okay. And you could get rexis in all cases.
Yes, sir. And in the
Okay.
rexis case, we got the.
So you've included only cases where there was a
Yes,
rexis.
yes,
Okay.
sir.
That may not be the thing. Even if you don't get a rexis, you can still get the nucleus. And many a times getting a rexis is a challenge in hypermature cataract.
Yes, sir.
Because you want to do your rexis, you will tear the zonules. You don't have a counter traction from the zonular side. So in an attempt to make a rexis, you may cause a zonular dialysis. So it may be worthwhile to actually just make even a capsulotomy big enough to admit the nucleus into the anterior chamber and put a three-piece lens in the sulcus. That could be one of the variations.
Okay.
The viscoelastic which you are using?
Ma'am, dispersive viscoelastics. Visco.
Okay. Because the thing is, in the hypermature cataract, the nucleus will be very hard.
Yes.
So when you're already putting a lens in the bag and then doing the phaco, the chances we are doing the phaco very near the cornea.
Yes, sir.
But somehow the cornea is clear. So
yes, sir.
Okay.
Thank you.
Satisfied.